Well, hello everybody. This is Dr. Alice Lee. Welcome to iCubed, episode 31. Believe it or not, it's 31 already. So
31, that's crazy.
Yeah. So I have a special guest today, Dr. Ali Raja, the infamous, he is editor-in-chief of New England Journal of Medicine Journal Watch. And I have the pleasure of having him as a guest. So why don't you introduce yourself, Dr. Raja?
Thanks, Dr. Lee. My name is Ali Raja. I am a practicing emergency physician here in Boston, Massachusetts at Mass General. And I can't tell you how excited I am about this. I've been watching the videos. I've really been looking forward to doing one with you. So thanks for letting me come on.
Oh, you're very welcome. I'm excited to have you on, actually. So I picked a very special case. This is an unbelievable case I had earlier this year. So let me just dive right in. So this is a 66-year-old male who has a history of agoraphobia, and he comes to the emergency department with chest pain, right?
Got it.
Let me just set up the scenario. Well, I am standing in the middle of my doc box, which has all the docs sort of sitting down. We're kind of chatting, and then I hear my charge nurse go, "Dr. Lee, I need a doctor. Come over here." And I was in the middle of all this noise, and I didn't actually hear it the first time he said it, and then he said it again. He goes, "EMS is asking for a doctor right now." So, I'm like, he's the charge nurse, okay? So apparently the patient had gone unconscious in the hallway. So I go over to the hallway, and I saw this very large unconscious man on the EMS gurney. I mean, it's sitting, the patient is on the gurney in the hallway. So just as I was trying to get a little bit of history from the EMS guys, the patient kind of starts having this tonic, clonic, jerking kind of activity, like a seizure. And the nurse says, it looks like VTAC because he was on the stretcher with the monitor from EMS, right? So I couldn't really see what the rhythm was. So they just kind of threw the guy on the bed. Yeah. And this is what the pre-hospital, can you see that? This is what the pre-hospital monitor EKG is. I don't know if you can.
Yeah.
But I had a moment to look at the EKG. This is before he passed out, okay, or went into this sort of seizure-like activity. So we get him on the monitor really quickly on the bed, and this is what we see.
Oh no, that's different. That's not at all what you just showed me.
I know. So we know that something's changed, obviously, because clinically he's unconscious now. So CPR gets started. We see that is, of course, VFib, and we shock him, and you can see that on the monitor strip. So in the meantime, I intubate the guy during the CPR, and we shock him, and I'm also calling out for amio, lidocaine, magnesium.
Let me ask you before you get into that, awesome resuscitation. How were you guys doing CPR? What were you doing? Did you have one of the paramedics who brought him in? Were they pounding on his chest? Did you have a Lucas? Did you have one of your techs? Were you there doing it with one hand while you were shouting out orders with the other? What'd you do?
It was actually pretty chaotic. So we're a community hospital. We don't have a mechanical device. So we do have the staff kind of rotating. We have ED techs, we have the nurses rotating. EMS was there, so they were rotating to try to do the CPR. We had multiple other people in the room, obviously. So I managed to intubate the patient. He's in VFib, so defibrillate him at 200, nothing, right? So we do that actually 4 times in a row. And in the meantime, I've called out for lido, amio, bicarb, just in case it's hyperK, and calcium, right? So we are doing CPR. We are doing these defibrillations without any effect at all, right? So then I'm thinking to myself, oh my gosh, what? I'm thinking, I'm going through my head all the things that you had to do for VFib. And I thought, dual pads. Because about 15 years ago, I had a patient in a different hospital I was working at, that one of the cardiologists I was on said to try it. It wasn't successful, but I had never heard of it. And then within the past year, if you've noticed, past year or two, it's been coming out in the foam ED world, right? So that was like my thought. Okay, let's just try. So we slap on a second set of pads. I said to put the second pad in the front and in the back, and just let's try the 2 pads, right? So we shocked him once. We shocked him twice, nothing. We shocked him 3 times, nothing. And I'm going, oh my gosh, what's going on, right? And so I actually go out to the hallway and I talk to the mom, elderly mom. I said, we've done everything, and I really don't know if there's anything more we can offer, right? So I go back into the room. I go, okay, where's my ultrasound? I do a POCUS at the bedside because, if he had no heart activity, maybe we shouldn't continue, right? And this is roughly, I can't be precise, but this is roughly about 20 minutes into it, something like that.
And how many times have you dual sequentially shocked him now? You
said three times already. Wow. 3 times, nothing. Okay, I talk to mom. I get my bedside ultrasound. Yep. And I'm slapping on to take a quick look because if there's no cardiac activity, we're not going to continue, right? I look at the heart, the POCUS, and there's disorganized cardiac activity.
It's still fibrillating.
Like, we got to keep going, right? Yeah. So then at that time, one of the ED techs looks at the pad. He looks up at me and he goes, Dr. Lee, is this pad here supposed to be in the back? I'm like, yes. I told him, one in the front, one in the back.
Oh, no.
Yeah, right. So the tech changes that pad and puts it in the back. And now we're shocking him for the 8th time in total. And this is the 4th time of 400 joules. And we're roughly 22 minutes into it, 25 minutes into it. And we shock him. And I look on the monitor. And for the first time, I actually see a rhythm. I actually see this very slow, Y complex rhythm. And I'm yelling, is there a pulse? Is there a pulse? No pulse. So I'm like, okay, epinephrine, continue CPR. And we go another 2 minutes of CPR like they recommend, right, in ACLS. And and now he's got a pulse and he's got a pressure. And we get an EKG and he's got an ST elevation STEMI.
Wow.
V1, V2, and V3. Okay. So I'm like, okay, we need to call the cardiologist on call, right? So now he's got ROSC. He's got a ROSC. I mean, he had that epi and he has ROSC. I activate the hypothermia. I
start cooling him, right?
Huh?
You start cooling him?
Yeah, well, I call it out. I've asked the charge nurse to get people involved. And then I call out the cardiologist who happened to be in the ER. So I show him this EKG. Yeah, exactly. I show him this EKG and he goes, oh, that's a STEMI. I said, yeah, we just...
I was just showing it to you for your opinion. I didn't know what it was. Why didn't you tell me what it was?
Right. No, yeah, so I said, we just shocked the guy 8 times with 4 times the dual pads. He's got a STEMI. Yeah. So long story short, we lost that initial EKG and I'm very sad about that. But the cardiologist takes him to a cath lab, right? And it's a near total occlusion of the left anterior descending coronary artery. And he puts a stent in it. So happy ending. After the stent, this is his EKG.
That's amazing.
And, I know.
And you had been out there talking to his mom about how nothing else was possible. And now you get to send her son home to her. That's amazing.
Right. Isn't it a shocking case? It's such an amazing
Have you been planning that fun for a few weeks, the shocking case fun?
Oh, well, yes, no pun intended. But anyway, it is a shocking case. So then long story short, or short story long, he actually left the hospital reportedly neurologically intact 2 weeks later. So this was my miraculous case.
That is an amazing case for so many reasons. The fact that this patient coded basically in front of you. He had a rhythm when he was with the AMS stretcher and coded right on your bed. The fact that you thought ahead to get an extra set of pads and an extra defibrillator. The fact that your tech actually noticed, right? This is a great example of everybody being able to speak up, right? If you were intimidating or had a different style, somebody might have been afraid to speak up, but your tech spoke up and said, actually, hey, maybe that pad, Dr. Lee wanted it in the back and mentioned it. That was such great teamwork.
So, as you know, I have 2 learning focuses for my screencast.
This is so great. I've seen so many of these that now I get to be part of one. I'm like, oh, now she's going to talk about her first learning focus. And there it goes.
You're so funny. Thank you very much. But it is important to kind of try to focus us because that case and all my cases are just fascinating cases that have so many learning points, and you can definitely get lost in all of that. So I want us all of us ER doctors who are so ADD, I really want to help us drill down to the most important parts of these cases. So for him, learning focus number one was treatment for refractory ventricular fibrillation. So as I did all of this research, and I kept reading different articles about it, I realized there's somewhat of a difficulty in actually defining refractory VFib. I think that this definition is excellent. So he says that refractory VFib or shock-resistant VFib is defined as a rhythm that fails to achieve sustained ROSC after treatment with single defibrillation shocks and administration of anti-arrhythmic medicine. And that makes common sense. I mean, it makes sense, and that's exactly what happened in my patient. I think that the number of shocks is not as important as understanding that refractory VFib is VFib that just is not responding to your standard treatments, which are meds and shocks, right? Dr. Pourmont also makes a bit of a distinction between refractory VFib versus recurrent VFib, and I'm not really sure this is operationally important, honestly. He says recurrent VFib is greater than 3 episodes of VFib in 24 hours. Well, I mean, if you're shocking a patient and then doing CPR after you shock, you don't really know if he completely went out of VFib or was he in VFib, shocked out of it, and then went back into VFib while you're doing your 2 minutes of CPR, right?
That is always possible.
So operationally, this distinction really is irrelevant almost. So I'm just going to keep with the term refractory VFib.
Yeah, you're going to be treating him the same either way.
Yeah, exactly. So then the treatment now for refractory VFib, I mean, it's not very specific in the ACLS guidelines. There's not much guidance in there. But what I'm finding in the literature is that treatment for refractory VFib are basically these 4 things: esmolol, ECMO, cardiac stereotactic ablative therapy, which, have you heard of that?
I haven't, but I imagine that it's something that happens in an EP lab and not the EP.
So it's actually kind of a last-ditch effort, but very interesting. I read one case report. I'll explain. And then the dual sequential defibrillation, which is also termed double sequential external defibrillation. Okay, so these are the 4 things I've found in the literature in terms of treating refractory VFib. Okay, and I'm going to talk about them actually in the context of case reports, because these are kind of they just illustrate the way they're supposed to work. These methods are supposed to work. So this first actually is a study out of Korea.
Excellent. Is this a good time to mention that you recently got back from Korea?
Yeah. Yeah, I guess Korea is on my mind. I went to the International Conference of Emergency Medicine in Seoul, and it was in English. Dr. Judy Titnelli was there, and I got to listen to some really world famous and very impactful speakers over there. So it was wonderful. So this study that I'm showing here in the on the screen here is a study out of South Korea, and it was actually back in 2016. Just a quick summary. The ESMO, the theoretical benefit is supposed to be that, during cardiac resuscitation, the endogenous catecholamine plus the external adrenaline and epinephrine has a very, very high residual in the body. And so the ESMO is supposed to really blunt any of the beta effects on the heart, which is, increasing oxygen demand as well as lowering the VFib threshold if you keep having all this catecholamine surge in the heart. So that's the theory behind esmolol. So in this particular study, they did sort of a pre and a post study, 12 months each phase, and they were 2 years consecutively. And then ultimately what they wound up was 25 patients without the esmolol, and then they had 16 patients who had resistant VF with the esmolol. And so basically what they found was that the esmolol group had a higher rate of sustained ROSC, and their survival to ICU and survival to hospital discharge with good neurologic outcome was higher in the group with esmolol. So, I mean, it's one study, it's small numbers, but it's kind of a study to demonstrate what I'm talking about in terms of esmolol being used for refractory VFib. So this case report is the first report of survival of a refractory VFib after dual axis defibrillation, which means the double sequential defibrillation and esmolol administration. This report came out of Michigan State University, Dr. Bohm et al. So basically, it's a case of very similar to mine, actually. This is a guy who is 67 years old, comes into the ER, and he goes into VFib arrest. So they do the CPR, they do the meds, the epi, the amiodarone, and they did 5 total biphasic defibrillations, which is close to what I had tried. The patient initially was intubated in the esophagus, and so they took it out and just continued PVM, but they continued to resuscitate him with dual sequential defibrillations at 300 joules at about 15 minutes from the resuscitation without any effect. So they added esmolol with the bolus and the drip. They did a second DSD at 21 minutes of resuscitation, and he got ROSC. And then, so he also did very well. He also had a mid-LAD STEMI, and he was stented, and did very well and recovered fully. So it was an interesting case because it's very similar to mine.
Absolutely. And you know, one interesting thing to mention.
Similar to mine. Very well recovered STEMI, and he was stented, and they did 5 total biphasic defibrillations, which is close to what I had tried. The patient initially was intubated in the esophagus, and so they took it out and just continued PVM, but they continued to resuscitate him with dual sequential defibrillations at 300 joules at about 15 minutes from the resuscitation without any effect. So they added esmolol with the bolus and the drip. They did a second DSD at 21 minutes. He also did very well. He also had a mid-LAD STEMI, and he was stented, and did very well and recovered fully. So it was an interesting case because it's very similar to mine.
Absolutely. And you know, one interesting thing to mention is that they mentioned dual axis defibrillation. And I think you talked about this too, right? Pad placement here, nobody really knows what's going to be better, whether or not you have sort of a front and side pad, trying to do this for the viewers, you know, sort of on the chest and then along the left side, and then a set of pads right next to it, or with that initial set of pads, having the second set of pads be an AP set of pads as well. So, you know, the former keeps the same axis and the pads are just kind of right next to each other.
Exactly.
And the latter actually completely changes the axis.
Right.
And so who knows which one's better, although intuitively it seems to me as though changing the axis might actually be better because you're potentially not in the right axis to begin with. And by changing it about 45 degrees, you might be more effective. One
of the mechanisms that's thought to contribute to success of DSD is the fact there's 2 axes, this discharge of electricity. So that those 2 articles were really good about explaining esmolol. In terms of ECMO, very, very rare and very, very select population. But this is a really cool case out of Taiwan.
You're really hitting the East Asian articles here. This is wonderful.
Well, I was in Taiwan and in Seoul this past month.
Were you in Taiwan too? I didn't know that. I knew you were in Seoul, but I didn't know you were in Taiwan.
Yeah, I went to Taiwan with my family after Seoul. But so this case report is about a 70-year-old male who went to the ER. He had chest pain. He went to refib in front of everybody. So the usual stuff, epinephrine, amio. They defibrillated him 3 times, no result. So then they were suspecting that it was an anterior, actually a left main as STEMI. So then they started the ECMO to set up ECMO. They used mechanical CPR device during the time they set up the ECMO. They got the ECMO set up, and then at about 35 minutes, they got ROSC. Okay, So then I'm not really sure how much time he was on ECMO by that point. But anyway, at 35 minutes, he got ROSC, and they went to cath, and he had a left main occlusion. Okay. Then they started, they stented him at about 100 minutes from the resuscitation, and he fully recovered. Wow. So I didn't really know anything about ECMO during, resuscitation, or what its purpose or why it works. But the idea is that they used ECMO in place of mechanical CPR during the transfer to a cath lab, and that will maintain perfusion to the vital organs, especially to the brain, right? So apparently there are studies out there that show that ECMO CPR is advantageous over just simple CPR in relation to neurologic outcome. And this gentleman recovered very well, apparently fully recovered as well.
It is, and we've done this a couple of times at my shop, and actually refractory VF is one of our indications for the use of ECMO, for our ECMO team to come down and to do it. And so the indications are cardiogenic shock, and number 2 on the list is refractory VF.
Cool.
Cardiac arrest without ROSC. And so if anybody wants to see those, by the way, they can always just download the MGH app. So if you go to the Apple iStore and just look for MGH, you can download our ECMO guidelines and show them to whoever you need to help get ECMO for refractory VF in your ED.
I thought this was a fascinating technology and option for refractory FIB. And this was just I'll quickly talk about, this is just one case report of a patient out of Heidelberg, Germany, where this guy was actually, he came in to a local hospital, was in, a cardiac arrest, and they resuscitated him, they stented him, but over the next day or so, he continued to have recurrent VFib. So this is not exactly an emergency case, but it was just very interesting. So I wanted to just quickly mention it. So he just kept having VFib and deteriorated in the hospital. They put him on Impella, and they put him on ECMO and transferred him to it's called the Heidelberg Center for Heart Rhythm Disorders. So they sent him to the specialized hospital, and the cardiologist there decided that they would stereotactically ablate the entire infarcted heart, anterior part of the heart. So they did that. They ablated that area, however they do that. And then reportedly, it took 2 weeks for all of the ventricular dysrhythmias, everything else to resolve completely. And apparently at 60 days of follow-up, the patient was fine. But highly, highly specialized. And obviously, like you said, in the EP lab, probably. But I just thought I would throw that in there because it's just an interesting.
That's amazing.
Yeah, I know.
That was even an issue, that patients would go into it on and off for a couple of weeks.
Yeah. So kind of a last-ditch effort for this guy. It's interesting that the title caught my eye, obviously, Risen from the Dead. All right, so I just wanted to make sure we talk about the methods or recommendations for refractory refib, the fourth of which is dual sequential defibrillation.
Number 2, excellent.
Yeah. And some of the articles I read were from Australia and other parts, and that called it double sequential external defibrillation. So you might see those 2 different ones. And speaking of Korea, at the conference, they had poster sessions every day. So you walk through the poster hallways, and I saw this one poster. I wanted to get in touch with them, but I didn't. But do you know where Sabah is?
No.
So Sabah is a province on the island Borneo.
Oh.
And Sabah is a district or a province in Borneo that is belongs to Malaysia. So this was the Emergency and Trauma Department Hospital, Duchess of Kent in Sandakan. Anyway, it's a case report of a young guy, 40s. He arrived in the hospital actually within 5 minutes, but it was very unsuccessfully resuscitated. They kept resuscitating, trying to, and they defibrillated meds and all that. And at 50 minutes, they got him back with the dual sequential, but he died about 3 days later. So it was really kind of late into his resuscitation at about 50 minutes when he regained ROSC. So that was kind of an interesting little case there. So I read multiple articles. I don't know if you had a chance to read some articles, but this is actually very, very recent. It's an update or actually a kind of a review, and it came out just May, as I was leaving for my trip. It came out in May in the American Journal of Emergency Medicine. And of all the articles I've read, this is really a very succinct, very nice summary of DSD and the recommendations. So I'm just going to kind of run through that as our time comes to a close here.
That's a great point. And, you know, one of the things I wanted to mention is there aren't a bunch of great randomized controlled trials, right? So, and I was doing research for this, as you recommend, and there's a lot of case reports, and there's some case series, and there's some literature reviews, but there's no RCTs. Rumor has it there's actually one in the works right now, but but there isn't any real evidence on this yet, except for a bunch of case series. So that's what we have is a lot of folks doing these case series. So I think this is as good a piece of evidence as we're going to get.
Right. So I fully understand that anecdotes does not data make, but we deal with humans, right? So we're not dealing with boxes of TVs and boxes of technology that are very consistent and very uniform between boxes and between units. So it's really important for us to talk about real cases, and then gather from the cases science, if you will, or data, and then try to apply that. So this article by Barrow et al. Out of Virginia, I think does a really good job. I would highly recommend people reading this, because it's a really good job summarizing what's out there right now in terms of scientific data and what's needed. So Barrow and his group talks about refractory VFib treatment is not well established, and that's why there's all these random cases out there, I think. It's very high mortality of 97%. Now, in terms of the technique or technology, dual sequential defibrillation actually has been established and done for many years. It started out in the EP lab, actually. And he talks about over the past 5 years, there's been lots and lots more literature and research and case reports. And he says that over this past year, in 2018, there was at least 4 review articles, and I got all 4 of them. I read all 4 of them. So he spent a lot of time on this, making this, or talking about his this one table here, which is he listed all the studies that were out there that were pertinent, and he was logging the number of standard shocks before the dual sequential shock, and then the amount of arrest time prior to trying the dual sequential defibrillation. And the bottom line is that they seem to be mostly late application of DSD and lots of single shocks prior to the actual application of the dual sequential. So he comes up with a proposed defibrillation strategy. I think it's very operational, very common sense. So first thing he thinks, or they think, that to call VFib resistant or refractory VFib when the VFib is unresponsive to 2 defibrillations. Then from the 3rd attempt on, or the 3rd defibrillation on, you should use dual sequential. And then he says, if there is not a second defibrillator around right away, so he said after your 2nd attempt, to take the pads and actually move them to a different location to change up the axis, as we kind of touched on earlier. And then use the appropriate amount of energy. So once you have a 2nd defibrillator, he says to go ahead and consider using the 2nd one at the same time. So that's, I think, pretty easy to remember that. Now, here's another article that really is fresh. It's April of this year on resuscitation. It's an observational study. And it's talking about, is there actually any kind of impact of dual sequential to terminating refractory VFib? So these were, this is a retrospective review. These were all adult out-of-hospital cardiac arrests with at least 3 single defibrillation attempts, okay? they wound up having 201 standard defibrillation patients, and then 51 that received at least one dual sequential external defibrillations. And overall, the VFib termination and ROS were actually quite similar between those two groups, with or without the DSD. But they did notice that the dual sequentials seemed to be more successful at terminating VF and getting ROS than the standard defibrillation in those in whom it was attempted early on. So after 4 shocks of standard shocking, they start, the dual sequentials, and that seemed to be more successful. They also found that the dual sequentials were more successful at VF termination in those they attempted even later on. So like from the 9th through the 17th attempt, the double sequential was actually more effective than stopping the fib. However, there was really no difference between the two different strategies, either single or double, in terms of ROSC when they attempted it late. So when you were attempting the dual sequential late, it really doesn't make a difference whether it's dual or a single shock. So that was kind of very interesting article, I thought.
Mentally, when I read the Bureau article, I was trying to just work through how I would implement this. And so what I was thinking through, I like to practice these things in my head before I actually have to do them, is if I have somebody who's coming in with VF, I'm going to shock them once with a standard base apex pad placement. That's just where they usually come in with EMS. And then on the second time, we'll shock them again. And if that doesn't work, what I was actually going to do is place a new set of pads in the AP location and hook our defibrillator up to that while we run to the other room and get the other defibrillator, which then we can hook up to the original pads. Because otherwise, if we're taking off these pads and then moving them around, well, we're going to need them again in just a second. We do the dual sequential. So open up a new set of pads, put them on the new axis, hook up your current defibrillator to that
the new axis
while you go and get your second defibrillator. And then you can actually shock them with the new axis and with both axes when you have both defibrillators already ready to go.
That's actually great. That's a great sort of micro suggestion to that, because in real time there are seconds to spare, if you will, and so I think that's great. That's a very good suggestion. I might have to do that the next time I have one of these.
Well, the only reason I say that is that the one thing that I've taken away from all the literature I've reviewed on this is that you have to do it quickly. So doing it on the 4th, 5th, 6th, 7th, 8th, 9th, 10th shock is going to be less effective than doing it on the 3rd. And so if we can get that hooked up as quickly as possible, I think we can maximize the chance of the dual sequential actually working.
Absolutely.
One interesting thing, while we were talking, I found that study that I wanted to tell you about. It's an ongoing crossover randomized trial being done in Toronto by the Paramedic Services. It started enrolling patients back in March of 2018, and it looks like it's going to finish enrolling patients this summer. And it's called the DOSE VF study. It's the double sequential external defibrillation for refractory VF study. They're enrolling 110 patients. They're randomizing them to either get dual sequential defibrillation or not. And it's going to be a real world pragmatic trial done in the field by an EMS agency. So hopefully they should be able to complete enrolling sometime this summer and hopefully publish the study results in the next 6 to 12 months. That'd be fantastic. And
that's exciting. All right. Well, Ali, thank you so much for joining me.
You are so welcome. This was so much fun. Thank you for letting me come on your fantastic show. I had a great time.
Well, you've been a great guest, and I think this topic is terrific. It's right on the forefront of foam, I think, at this point, and I'm honored and privileged to have someone like you on my screencast. So I hope we can do this again.
I hope so too. It was a really great time. Thanks for such a great set of educational slides. Those were really well done.
All right. Well, I'll see you later, maybe at ACEP, but. So everyone, thank you so much for watching this month. I appreciate everybody's support, and I hope you're learning something from my endeavor. This is my labor of love, and so hopefully you will see me at a conference coming up. I'll be at ACEP, and you can come by and say hi. I promise I won't bite. Okay. Take care. Bye, Allie.
Thanks. Bye, Dr. Lee.